It is my pleasure to present our multi-institutional analysis of 100 consecutive patients with COVID-19 and severe pulmonary compromise treated with ECMO. Our disclosures are shown on this slide. All of us have had our very existence impacted by the COVID-19 pandemic. Indeed, life as we know it has changed dramatically, stunningly, rapidly, and globally. The evolution of the treatment of patients with COVID-19 is unlike any event ever seen in medicine. As of October 24, 2020, 42,299,535 patients around the world have been diagnosed with COVID-19, with over 1 million associated deaths, calculating to a 2.71% mortality rate worldwide. Meanwhile, in the United States of America, as of October 24, 2020, over 8 million patients have been diagnosed with COVID-19, corresponding to over 200,000 associated deaths and a corresponding mortality rate of 2.64%. The purpose of this manuscript is to review our multi-institutional clinical experience in 100 consecutive patients with confirmed COVID-19 and severe pulmonary compromise supported with ECMO at 20 hospitals, and to document outcomes and trends in management over time. A multi-institutional database was created and utilized to assess all patients with confirmed COVID-19 who were supported with ECMO at these 20 hospitals. This database is a component of the Specialty Care Scope database. Statistical methodology is shown on this slide. This figure depicts the distribution of all 100 patients by category of outcome. 42 patients died on ECMO or within 24 hours of decannulation. 8 more patients died beyond 24 hours after decannulation but prior to hospital discharge. And 50 patients currently survive, with 49 discharged from the ECMO providing hospital and 1 still in the ECMO providing hospital. Mean and median age of all patients was 50 and 51 years respectively. 2/3 were men. Survivors were younger than non-survivors, with a median age of 47 years in survivors and 57 years in non-survivors. This graph depicts the distribution of the age of the patients, comparing the survivors with the non-survivors. Again, survivors were younger than non-survivors. 1 or more pre-COVID comorbid condition was present in 80 out of 100 patients, including obesity in 57, hypertension in 39, diabetes in 37, and asthma in 20. No difference in pre-COVID comorbid conditions were present in survivors versus non-survivors. Mean and median time from COVID diagnosis to intubation was 4.9 and 3.5 days, respectively, and mean and median time from intubation to cannulation was 4.5 and 4.0 days, respectively. No difference in these time intervals were present in survivors versus non-survivors. Mean and median time on ECMO was 16.9 and 12 days, respectively. Again, no difference in this time interval was present in survivors versus non-survivors. This figure depicts the distribution of hours on ECMO, comparing the survivors with the non-survivors. Again, no statistical difference was seen between survivors and non-survivors. Adjunctive therapies received while on ECMO were remdesivir in 34 patients, convalescent plasma in 44 patients, hydroxychloroquine in 37 patients, interleukin blockers in 45 patients, prostaglandin in 33 patients, and steroids in 54 patients. No statistical difference was seen in the use of these adjunctive medications and therapies between survivors and non-survivors. This fascinating figure depicts monthly trends over time in the utilization of these 6 adjunctive therapies in patients with COVID-19 while on ECMO during the 5 months of this analysis. The use of remdesivir, interleukin-6 blockers, and steroids increased notably, while the use of hydroxychloroquine and prostaglandin plummeted. Veno-arterial ECMO was used in only 4 patients with only 1 survivor. Meanwhile, veno-venous ECMO was used in the remaining 96 patients with 49 survivors. In conclusion, our analysis of 100 consecutive patients at 20 hospitals reveals that ECMO facilitates salvage and survival of select critically ill patients with COVID-19. Survivors tend to be younger. Survival of patients supported with only veno-venous ECMO is 51% in our cohort. Substantial variation exists in drug treatment of COVID-19, but ECMO offers a reasonable rescue strategy. Additional gathering and analysis of data will inform appropriate selection of patients and provide guidance as to the best use of ECMO in terms of timing, implementation, duration of support, and best criteria for discontinuation. Expansion of studies, such as the current analysis presented here, will provide a means to further define the role of ECMO in the management of severely compromised patients with COVID-19, and will serve to refine the optimal use of ECMO in these patients, with the goal of continuing to enhance survival. Thank you.